G junction, they are now classified as gastric cancers. So this disease of the G junction and lower esophageal tumors, they behave differently than the uh, classical gastric cancers. They are treated differently with different modalities and different philosophies. So the classical gastric cancer, which is the non-cardiac of the body of the stomach, we body fundus and the pylorus of the stomach, we will be dealing with this. So that's my disclosure number one. So let's get things into perspective, and we start with one case so that we all get to the groove of the topic. This is a 50-year-old male, a non-smoker without any comorbidities. He had weakness for last 2 months and a weight loss of around 3 kgs. CBC revealed a hemoglobin of 7.2. He was evaluated for this anemia and he was found to have iron deficiency anemia. Now we know for iron deficiency anemia in a male, the first thing we do is an upper GI endoscopy to rule out any bleeding ulcers there. We did it, and there was an ulceroproliferative growth in the lesser curvature. CCT showed that there were no nodes. It was a clinically T3N0M0 disease on CT scan. He visited a GI surgeon and he was planned for upfront surgery. He underwent a total gastrectomy. The signet ring cell adenocarcinoma was there. It was a margin negative R0 resection with D2 lymphadenectomy. 18 lymph nodes dissected, 2 positive. So the pathological staging was PT3N1, and all this happened on 2nd of January 2020. Now, what happened was that this patient developed some post-op infection. It was a fever of unknown origin. He had some pus collection in the abdomen. It was drained with a pigtail, and slowly he recovered, but this took around 2 months' time, and then he was referred to oncology hospital on 3rd of March 2020. And he is PS1 now. Now the question begins. He meets a medical oncologist, Dr. M. Okay. He convenes a tumor board and has a discussion. So what is the best option for him right now? So someone says it's adjuvant chemoradiotherapy. Some other says no, adjuvant chemotherapy with capox. And one of the older persons in the room said, no, there is no role of this any adjuvant now. It's too late. It's already 2 months' time. So these are questions to be discussed. Had he visited this oncology center in the first place without visiting a surgeon in the first place, what would this, he must have been discussed in the MDT, and what would this MDT decide then? These are the list of options, all of which can be tried. Some are evidence based, some are not, but definitely these are practice which differ from place to place. It can be surgery followed by chemotherapy, upfront surgery followed by CTRT, NSCT surgery, then adjuvant, which is called a perioperative chemotherapy, that is chemo both before and after surgery, or it can begin with NSCT, then surgery, and then an adjuvant chemoradiotherapy, or only chemotherapy followed by surgery, or chemoradiotherapy followed by surgery, and it can be a definitive CTRT. So all these are options. So what did you choose? So definitely there is a role of confusion. These are the questions which comes to our mind while we think about adjuvant, neoadjuvant treatment of stomach cancers. Now another question that is very important is that had the HPA report, histopath report been different, had it been a D1 resection, had it been a T3N2, only 6 nodes dissected and 4 positive, would your choice differ then? So these are the questions I will be dealing with in my presentations, and you will find the answer for each one of them. Other questions are, what is the best approach to treat these patients of stomach cancer? Does this signet ring cell which was made in the initial slide, does this thing matter? Or next question is, did he miss the bus by waiting for 2 months to recover? This is a very practical situation in our clinics. What survival do we expect? And should we do a HER2/neu and add targeted agents for this patient in the adjuvant setting? So these all questions will be answered in this talk. So my agenda will be like this. I've started with the case review. Then I'll give you the principles of multidisciplinary management. Then I'll split the thing of adjuvant therapy into certain simple questions, which makes it easier. That is, whom to give, why to give, how much to give, when to give, what to give. what to give. The most important things are adjuvant chemo or radiotherapy, and what are the landmark studies for each of them which provide the evidence behind this. What is the perioperative chemotherapy? What are the landmark studies for this? And what are the comparative studies? And what are the newer comparative studies? Then I will spend some time on the role of MSI, which is a very burning topic in adjuvant therapy of gastric cancers. Then newer strategies, and finally I will give you a gist of how I manage these in my practice. So let's begin. So what is the best approach? The best approach depends on where the patient is, where the patient resides. It depends on the geography. Suppose you are in a US hospital, you will be treated with limited surgery and then you will give an adjuvant chemotherapy and radiotherapy, chemoradiotherapy. And what is the basis of this? This is because of the landmark trials Intergroup 0116 and CalGB 80101. This provides the evidence for this practice there. Now move across the Atlantic to Europe. Doctors here, the multidisciplinary teams here will treat you, the same patient of stomach cancer, with perioperative chemotherapy. That is, they will give chemotherapy first, then surgery, then again chemotherapy. And why will they do so? Because they have studies, they have done studies like this which provide evidence to them. We have the MAGIC trial from United Kingdom, we have the FNCC LCC trial from the French group, and of late we have the marvelous FLOT trial from the German group. All these are European trials, and that is the basis of their practice there. If you go far east towards the Far East, to Japan, Korea, and China, here you will see Japan and Korean people, doctors will treat with a radical surgery, very, very radical surgery, extensive lymph node dissection, and then they will give only adjuvant chemotherapy. And what is the basis for this? They have done studies like this. They have ACTS studies of S1, then classic study of CAPOX, and of late the newer JACRO study. All this provide evidence for their practice in their part of the world. So the treatment of gastric cancer, localized, locally advanced gastric cancer, depends on geography. Now this is reflected in the ESMO guidelines which were published in 2016, and why this is so? Because of this varied practice. So gastric carcinoma, which is operable T1N0, that gets endoscopic or limited resection. Anything which is more than T1, that is T2N0 onwards, the preferred pathway is this: preoperative chemotherapy, surgery, and postoperative chemotherapy. And then follow the dotted lines. There are other pathways which the ESMO acknowledges that they are also relevant pathways, they are evidence based, and this is go for upfront surgery and then give adjuvant chemoradiation. Another approach is go for surgery and give adjuvant chemotherapy. So all these are valid approaches, all are evidence based, and the ESMO recognizes all of them, but the preferred pathway for them is this. Now we will look at each of these with their evidence basis. Now the strategy first is upfront surgery. Now the questions here will be, what after upfront surgery, what to give? Why to give adjuvant? What benefit will adjuvant give us? Whom to give adjuvant? Whom not to give adjuvant? And then when to give adjuvant? What are my options? What to give? And comparison of landmark trials, how much to give and what to expect. And what is the rationale for this approach? This approach says that if we do a surgery upfront, there's an accurate documentation of T and N stage, so we are not over treating anyone. We get a better risk assessment, and we get a better local control. And definitely, surgery followed by CTRT or surgery followed by chemotherapy both have level 1 evidence. We have phase 3 trials for both for chemotherapy and CTRT. And to top it all, with this approach, everyone at least gets a surgery. Now, the first question is whom to give adjuvant. Now, the NCCN guidelines say that any PT3 above or any node positive, these patients will receive adjuvant. They should be given adjuvant. There is some confusion over PT2N0. T2N0 is 1B disease. It is the ESMO guidelines say that yes, they should also be given adjuvant, but in practice for the NCCN guidelines, there are certain recommendations for PT2N0 again. Now, why to give adjuvant? What will be the benefit? How much is this benefit? At 5 years, 10%. This is the figure we quote. See, at any if you look at any of the adjuvant trials, be it CTRT, the US intergroup trial, it's 10% benefit, 5 years OS. If MAGIC trials, the Japanese trials, everyone is in the range of 9, 10%. So that's the figure of 10%. We the off late the trials, the flawed trials are giving us more, but 10% is the at least benefit of adjuvant therapy we get in adjuvant gastric cancer. Next, very important $1 million question is when to give. What is the optimum time for this patient in question? The optimum time is unknown. Most clinicians will give adjuvant chemotherapy within 6 to 8 weeks of surgery. Why? Because most adjuvant trials have been like that. But in practice, you will get complications. Post-operative morbidity is high, and these patients will need time to recover. So, 8 weeks, by 8 weeks starting chemotherapy, this will be for a minority of patients. Many more patients will be able to start within 12 weeks. So, practically, we take a cutoff of 12 weeks because beyond 12 weeks, the benefit of any adjuvant therapy declines. So, there was a study by Ahmed et al. In 2014, and they studied the DFS between those who received adjuvant chemotherapy within 8 weeks and more than 8 weeks, and they found that there was no difference. But this is a single study. Whether there is a delay in starting adjuvant chemotherapy beyond 8 or even 12 weeks, whether it compromises outcomes is not clear. A study by Park et al. From Korea, they show yes, there is a compromise, but the same journal had next year there was another study by Greenleaf et al. Which shows that no, it does not compromise. So the practice most of the centers is 3 months cutoff, 12 weeks. Now, the next question is what to give in adjuvant therapy to a patient of gastric cancer who has received upfront surgery. What to give? Now, there are two options. We can give adjuvant chemotherapy, we can give adjuvant chemoradiotherapy. Both of these have level 1 evidence, but the context for these levels of evidence is different. What is the context? The context is the different types of surgeries. Now, you have to pay attention to this. The surgery of gastric cancer has to be an R0 resection with a complete lymphadenectomy. There are definitions of D1, D2, and D3. So this has to be clear that D1 lymphadenectomy means that is removal of nodes which are adjacent to the stomach around the lesser curvature, along the greater curvature. D2 means that is removal of lymph node which are along the branches of the named arteries, which are the branches of the celiac axis. And D3 means nodes along the aorta. Now, if we recapitulate our clinical applied anatomy, this is the celiac axis and it has 3 branches. This is the left gastric artery, this is the splenic artery, and this is the common hepatic artery. Lymph nodes stations around these arteries, these named arteries, have to be removed and have to be labeled properly. And that will be called a D2 dissection, and that is the standard of care. The station number 10 lies here somewhere in the splenic hilum, and it is very difficult to remove it without a splenectomy. Now, let us see our options one by one. What is the evidence for adjuvant chemoradiotherapy? This is the US practice, and this was based on a landmark study which was published in NEJM by John S. McDonald in 2001. Here, the R0 resected gastric adenocarcinomas were randomized to observation or to combined chemo plus radiotherapy. They gave 5-FU leucovorin first cycle. Then this was a bolus infusion, 5 days on every 28 days. And then there was radiation, and for the first 3 days and the last 3 days of radiation, first 4 days and the last 3 days of radiation, they received 5-FU and leucovorin bolus injections. Then there was a 1 month gap, and then again 2 doses of this bolus 5-FU leucovorin was given. And what was the result they got? This was an updated analysis. One was published in 2001, and this is the updated 10-year analysis published by Smalley et al. And this shows that the benefit, there is an overall survival benefit and a relapse survival benefit even at 10 years. And how much is the benefit? The median survival is of 5-FU leucovorin and RT group was 35 months, as compared to the observation was 27 months, and the p-value was significant. The 5-year OS was 43% versus 28%, with a good hazard ratio of 1.32. Now, if we dissect out this, who did benefit? Anyone who had a D2 lymphadenectomy, there was no evidence of benefit. D0 or D1, definitely there was benefits. In the in the intestinal type, there was a definite benefit of chemoradiotherapy. And in women who had a diffuse, that is signature cells, they did not benefit. Now there was severe criticism of the US of this trial because the surgery was suboptimal. The D0 resection, where it was there in 54%, and D1 resection it was in 26%. The D2, which was the standard of therapy care, was present only in was done only in 10% of the cases. If we see the patterns of failure, there was similar frequency of distant metastasis in both the groups, chemotherapy or the control group. And there were toxicities. Hematological toxicities 54% and gastrointestinal 33%. And this led to the with cessation of chemotherapy for quite a lot of patients. Now, this was the trade-off. Now, years later, somebody CalGB 80101 was done, and this compared the same old McDonald regimen with something better. They tried to improve the chemotherapy partner of this by introducing ECF, which was by then the standard after the MAGIC trial. So ECF was given, followed by CTRT, which was the same as the intergroup trial, followed by ECF again 2 cycles. They expected that it will improve the overall survival, but there was no improvement in overall survival. Only thing was that this arm was better tolerated. The ECF arm was better tolerated. What does this mean? This means that if you improve, if you give more chemotherapy, if you add chemotherapy to this to these patients, whether you give ECF or 5-fluorouracil, the overall survival does not change. But this 5-fluorouracil bolus is toxic. It is not an optimal regimen to at present. Now, how do we give CTRT? In the McDonald trial, it was given like this. Day 1 to day 5, it was given the bolus injections, then radiotherapy, 28-day radiotherapy. Then there was a 1-month gap, and then in the radiotherapy, it was given for first 4 days and last 3 days of radiotherapy. Again, 5-FU and leucovorin were given, and 1 month after that, we resumed 5-FU leucovorin boluses. Now we all know that 5-FU and leucovorin bolus is not is a very suboptimal form of chemotherapy. It causes a lot of toxicity like diarrhea, mucositis, etc. So what we do nowadays is called a modified McDonald's protocol. Here we start with the course A. This is replaced by capecitabine single agent, 1250 milligram per meter square. We give it day 1 to day 14 every 21 days. Then it is followed by the course B, where radiation is started, and concurrently we give capecitabine at a dose of 825 milligram per meter square, and it is given on the radiation days, that is day 1 to day 5 every week. Then 1 month gap, and then again course C and course D, which is same as course A, are given. There are other modifications also. For patients who have a lesser performance status, it can be given as a degramont, that is 5-FU leucovorin. 5-FU can be given as a prolonged infusion of 46 hours in the degramont regimen every 14 days. This can be given for the course A, C, and D. And during the CTRT, if the patient cannot tolerate capecitabine also, and these are often the elderly patients, then they can be given continuous IV infusion of 5-FU 200 milligram per meter square every day. So this is how CTRT is administered at present times. Now come to the adjuvant chemotherapy options. What options do we have? We have 3 options. One S1, which is available in Japan, then Capox, and then the latest option is S1 plus docetaxel. I would mention that by 2010, we had a lot of studies in Europe which had adjuvant chemotherapy. And although they were small, they were not well planned, but a pooled meta-analysis of all of these showed that yes, there was a benefit, 5-year benefit of adjuvant chemotherapy over surgery alone. And then came these studies. In 2011, Japanese study of ATCS GC was published, and this was patients with stage 2 and 3 gastric cancers. After D2 dissection, they were randomized to 1 year of S1 therapy, oral tablet S1 therapy, and versus observation. You all know that S1 uh, is an oral form of 5-FU. It has three agents, what is Tegafur, then we have Gemeracel, which inhibits DPD, and we have potassium oxonate, or which is called Uteracel, which inhibits intestinal phosphorylation, which prevents diarrhea. But this agent is not available in India, it's available in Japan only, and it is given for 4 weeks out of every 6 weeks fashion. And what was the result? The 5-year overall survival was significantly better in the S1 arm. In the surgery arm, it was 61%. In the S1 arm, it was 71%. It is significant hazard ratio. Now, if we look at this, the 5-year OS control, this is very good. This is too good as compared to the uh, Western studies. If we see the magic, which I'll tell you later on, the the chemo group had 36% 5-year overall survival. The intergroup trial, CTRT trial, we just saw, the 5-year OS was 43%. Even in the FLOT, it's only 45%. And the control arm in this study is behaving so well that it is 61%. So these are a different lot of patients, and the Western world does not accept this. Now we come to the second option. This is the classic trial. This was the trial published in 2012. It was done in Korea, China, and Taiwan. This was adjuvant capecitabine and oxaliplatin for D2 resected gastric cancers. So it says 2, 3A, and 3B gastric cancers, D2 resected, 6 weeks prior to randomization, and they were randomized to treatment arm of one is adjuvant, no adjuvant observation versus 8 cycles of Capox or Zelox, capecitabine oxaliplatin, that which comprises 6 months. 8 cycles means 6 months of therapy. It is a 21-day cycle, and we can see that this is a clean gastric cancer trial. We have gastroesophageal junction is only just 2% or 3%. These are mainly located in the classical non-cardiac gastric cancers, and we had N1 and N2 status are equally compared in both the groups. And 67% of these completed the protocol chemotherapy, and this is the overall survival. We see an impressive hazard ratio of 0.66, 0.6, that is 33% reduction in the risk of death, and the p-value is very significant for the Capox group. So adjuvant chemotherapy is giving a very good benefit for a D2 resected gastric cancers in this trial. And this is the foundation for the Capox therapy practice we give in adjuvant chemotherapy nowadays. This is the base. This trial forms the basis of that. It is the practice for majority of the medical oncologists in today's world. Now, in last year, in 2018, in there was a trial was published. Was called the JACRO GC07. They thought of adding docetaxel to S1. So taxane plus 5-FU in the adjuvant setting. Does it improve survival? So this is addition of docetaxel to oral 5-FU, that is S1. Does it improve survival? So the study was planned like this: D2 gastrectomy, 3A to C. Look at the audacity: 20 to 80 years patients were included. 1100 patients. They were given S1 plus docetaxel and S1, all for 1 year's time. And these are the result. This is the 3-year disease relapse-free survival, which was the primary endpoint. This is for the total population. This is for 3A. This is for 3A and 3B. And in all these, we get the 3-year relapse-free survival was significantly better in the docetaxel arm. So that is, S1 plus docetaxel is fares better than the S1 arm. But this was highly toxic. There was a high chances of diarrhea and neutropenia, because both S1 and docetaxel, both 5-FU and docetaxel cause diarrhea. So this has not been accepted in general practice outside of Japan. Now, this is the recent most meta-analysis, which was in 2013. I showed you one in 2010, and this is the Cochrane meta-analysis, and it showed the benefit of adjuvant chemotherapy for resectable gastric cancer. How much is the benefit? This 35 trials, 34 studies were done, and the overall survival, it gives a 15% reduction in the risk of death. Hazard ratio is 0.85, and for disease-free survival 0.79. And these are high quality evidence of the benefit of adjuvant chemotherapy for D2 resected gastric cancer. resectable gastric cancer. Now, if you look at this is the intergroup graph. This is the Japanese study S1 graph, ATCS G6 study. This is the red line. This red line is a 60% survival. This is the 60% survival. You see the control arm, everything is above this red line, and you see everything is below this red line. So much of a difference. Why? Why is the Japanese population behaving so well, and the Western population not behaving like that? The reason is surgery. This D2 surgery is done in 100% of gastric cancers. This study, 100% of gastric cancer, they received D2. And why D2? Why is it not possible in the Western or the Caucasians? The Japanese people are at least 10 years younger. They are leaner. They are not as much fatty. They have less comorbidities. And mind it, this study was randomized after the surgery, not before the surgery. So this all this leads to the better outcomes in Japanese patients. So everything depends on this surgery. Surgery is the key. This cartoon shows that this is the surgeon's domain where we can do a curative resection. This domain is the metastatic, that is peritoneal mets, hepatic mets. No surgeon can cure this. Any surgeon can cure this when it is T1, that is we can do endomucosal dissection. Any surgeon can cure this. No surgeon can cure this. And within this realm, we have an area of, we have a cohort of gastric cancer patients which is entirely dependent on the surgeon. Surgeon D2 gastrectomy matters here, and this results in the survival difference. It's the key to survival of these patients. And we know that D2 lymphadenectomy saves lives because it decreases local relapse and it decreases cancer-related death. And we got this from the Dutch cancer trial, the Dutch D1 D2 trial. Now the surgery, quality of surgery is the key. Just to mention, if we see McDonald's, the difference is 10%, 19% versus 29%, because 10%, only 10% had D2 resection. If we see this S1 study, what is the difference between surgery and surgery and chemotherapy? 2.1 versus 1. This is a 1% difference, and 100% had D2 resection. And 5% difference if 100% had D2 resection. So surgery, quality of surgery is the key. Again, if we have a high volume center where the surgeon performs more than 40 surgeries, 40 esophagectomies, or more than 20 gastrectomies a year, then we have less morbidity and less mortality. This was found from this study. So the surgeon's quality, surgical quality matters a lot in gastric cancer. Now we come to the million-dollar question. Isn't adjuvant chemotherapy sufficient? Do we need adjuvant radiation at all? So the answer to this is we do not need RT if there has been a D2 resection. What is the evidence for this? I'll come to this. ARTIST 1 and 2, and we have retrospective studies from the Dutch group. But RT will benefit in anything which is less than D2. And what's the evidence? Because the intergroup trial says so. The CalGB trial says so. Now let us this. The Dutch observational studies showed that if this was a D1, D2 study, if we have a D1, then there is a benefit of chemoradiotherapy over surgery, for local recurrence as well as for overall survival. The moment we turn to D2, the red one, this chemoradiotherapy graph goes down. There is no difference of surgery versus surgery plus chemoradiotherapy if we do a D2. But this is retrospective. So adjuvant CRT has no survival or recurrence benefit over D1, but has the benefit over D1, but not over D2 surgery. But this is retrospective evidence. Now come to prospective evidence. This is the ARTIST trial. It tries to answer the question, does RT add to D2 resection? So it was first published in 2012, and then the updated was published again in JCO in 2015. These were all D2 resected gastric cancers, stage 1B to 4, and they were randomized to XP arm and XPRT arm. There is capecitabine cisplatin, 6 cycles of cape-cis versus cape-cis plus capecitabine, the capecitabine cisplatin along with RT, again cape-cis. So this RT was not with only capecitabine, it was with capecitabine plus weekly cisplatin as well. There is again a pure gastric cancer trial did not have esophageal or G junctions involved in it. And this was the 40 lymph nodes were the median number of lymph nodes which were dissected, and median lymph node positivity was 3 in both the arms. And what do we see? There is no benefit, no difference in disease-free survival between the XP, that is chemotherapy, or the chemoradiotherapy arm. And, if we see, the p-value is 0.92. Now, if we see the subgroup analysis, in the lymph node positive disease, there was benefit of CTRT. If and again, in the intestinal variety, there was a benefit of CTRT. So there was a need to try this to perform a separate study specifically on this lymph node positive population. So ARTIST trial showed that adjuvant CTRT does not benefit over CT, with some caveats. Okay, but there was criticism for ARTIST study, and you should know this. Even though the ARTIST trial met its accrual goal, both arms did better than anticipated during the sample size calculation. So the number of events was smaller than planned, resulting that the study has become underpowered for the planned endpoints. And so many of the experts believe that it cannot definitely disprove the value of chemoradiotherapy. So came the ARTIST 2. Now they took only the lymph node positive ones. 900 patients, D2 dissected gastric carcinoma, adenocarcinoma, stage 2 to 3, all were lymph node lymph node positive. It is because the ARTIST 1 had showed that radiation benefits lymph node positive. So they took only the lymph node positives, and they were stratified. They also planned to take only the intestinal ones, but ended up taking both intestinal as well as diffuse varieties. And then they were randomized to 3 arms: the green one, yellow one, and red one. The green one is 1 year of S1, yellow one is SOX, S1 and oxaliplatin 6 months, and this is SOX RT, that is SOX 2 followed by S1 RT against SOX 4. So the primary endpoint was disease-free survival. 3-year disease-free survival. S1 arm, it was poor at 64%. The SOX arm was 78%, and the SOX RT arm was 73%. At a median follow-up of 37 months, the Data Safety Monitoring Board asked this trial to be halted. And if we see these 3 graphs, the S1, the blue one, is the S1 arm. It fares worse, while the SOX and SOX RT both are doing equally good. If we see the subgroup analysis, then S1 versus SOX or SOX RT, there was a significant difference. But if we see chemotherapy versus chemo RT, that is anything of S1 or SOX versus SOX RT, there is no difference. Again, here there was no difference between SOX and SOX RT, although this was not the primary endpoint, but SOX and SOX RT, there was no difference. There was no difference. So not even in N1, in node positive chemotherapy, chemoradiotherapy is better than chemotherapy. But there were definitely criticism of each and every trial. For the criticism of the ARTIST 2 is that it was designed to compare. Whenever you have a 3-arm study, we compare 1 with 2, 1 with 3, and this is how the sample size is calculated. So designed to compare S1 versus SOX RT, it was designed, and S1 versus SOX. It was not designed for SOX versus SOX RT. So how can you answer this question? So there is no answer to this. And again, there was an early halt. This trial was stopped by the Data Safety Monitoring Board at 161 DFS events, and the calculated was at least we needed 226 events, and finally OS was not reported. So even with this criticism, if we have a look at the graphs, we see that even in node positive patients, it is very evident that S1, that SOX RT is not better than SOX. They seem to be the same. So I conclude that if we do not need adjuvant RT if there has been a D2 dissection. ARTIST 1 says so, ARTIST 2 says so, and Dutch retrospective analysis also says so. But RT does benefit anyone who has a less than D2 dissection. So give RT wherever you are not confident for that the surgery has been D2. And the evidence comes from the intergroup trial itself. Now there was one trial which directly compared chemo versus chemo RT, and this was the only trial in the world which has shown that CTRT is better, and this was given with IMRT. This was a very small trial done in China. It was a 68 patient study, T3, T4 or N positive after D1 or T2 resection, they were randomized to concurrent CTRT. It was given exactly like the intergroup study, but with intensity modulated radiotherapy, and versus the chemotherapy. There was nothing wrong in the plan, but this chemo arm was that old fashioned. You don't give this thing in 2012. It's 5FU and leucovorin bolus. And they showed that CTRT was better, but nobody is going to accept, because this chemo arm is not standard. It's a very, very weak chemo arm, and it's a toxic chemo arm, and it's a small study. So this is the only study which has given us that chemo RT is better than chemotherapy, but nobody is going to accept this small study with a weak chemo arm. Now we come to the preferred pathway, this one. This is the perioperative pathway. What are our options here? So what is the advantage of this pathway? Advantage is that we are giving chemotherapy to downstage the tumor and nodes. We are delivering chemotherapy before surgery because this is easier. This is better tolerated. This is a very practical thing. The tolerance decreases after surgery. So it's better to give it upfront. We did the same for esophagus. We are doing the same for rectum. Better compliance is achieved if we give things, if we start at least things pre-operatively. And then we have OS benefit. We have level 1 evidence of 3 different clinical trials which show that perioperative chemotherapy works very nicely. And the last but not the least, it prevents futile surgery. Suppose you start with neoadjuvant chemotherapy and then you find the disease has progressed. You are saving these patients from futile surgeries. So you are choosing the right patient. Now the disadvantage is that if you have some residual tumor, will we expose the tumor to the same chemotherapy again? You know that it did not work. It could not melt it. Now, if there is still residual disease, are you going to give the same chemo again? This is what perioperative chemotherapy says. Then again, post-op delivery again remains a challenge. For every perioperative chemotherapy or chemoradiotherapy study, giving the post-op portion is extremely challenging. So these are the advantages and disadvantages of this perioperative chemotherapy. Now let us see evidence. Now whom to give? Now any T2 or N positive onwards, T2 or N plus or minus, we will give this. We will start with the preoperative chemotherapy. Now whom not to give? This is very important. Any patient who has gastric outlet obstruction, who is vomiting, who is not accepting oral feeds, do not go for this venture with perioperative chemotherapy. You will land up with trouble. You will not benefit the patient. So first go for surgery. First go for either a curative surgery or at least a bypass surgery, gastrojejunostomy, to relieve this obstruction, and then only you can start with anything chemotherapy. If the patient is actively bleeding, you won't be successful in delivering your chemotherapy. If the patient has poor performance status, improve it before you start this venture of perioperative chemotherapy. Now, what are your options? Depends on the performance status. If we have excellent performance status, PS 0 or 1, then we have 3 options. We have the magic option, that is ECF, triplet chemotherapy, epirubicin, cisplatin 5FU. We can replace this 5FU by X-Zeloda. Or the French group, we have the PF, cisplatin 5FU. Or we have the German style, that is the FLOT, that is docetaxel, 5FU, and oxaliplatin. Now, for a PS2 patient or an elderly patient, you can try a doublet. You can give Folfox or Capox. We do not have studies directly for this, but you can extrapolate this from the classic trial. Now let us see evidence one by one. Now, the enthusiasm for this perioperative chemotherapy strategy came from this MAGIC trial. MAGIC stands for Medical Research Council Adjuvant Gastric Infusional Chemotherapy, MAGIC trial, which was published in NEJM in 2006. It was a landmark paper by David Cunningham from the Royal Marsden. Then adenocarcinoma of stomach or the lower third of esophagus, that is, it was a mixed, both stomach and GE junction and lower third of esophagus. They who were suitable for curative resection, they entered this study. They were randomized into the surgery arm or to the chemosurgery chemo, CSC arm. That is preoperative chemotherapy, 3 cycles of ECF, then surgery, then again 3 cycles of ECF. And the primary endpoint was overall survival. Now let's see what they got. This is the overall survival. There was a significant improvement in overall survival. The 5-year survival for the chemo surgery chemo arm was 36%, and while for the surgery arm it was 23%. Significant hazard ratio of 0.75. The median survival there was a 4-month increase in median overall survival. Similar benefit was for PFS, and we got a PAT CR around 8% of the patient. If we see the post-operative deaths, post-operative complications, and median duration of treatment, both of these were same. So delivering chemotherapy before surgery did not compromise the surgical outcomes, did not compromise the surgery. Now there were limitations of this magic trial. That non-standard surgery was again the problem here. Many patients had less than T2 resection, inaccurate preoperative staging, and then higher percentage of patients in the chemo arm underwent curative surgery, 79 versus 70. Then early stage disease was more in the chemo arm, and only 42% completed the protocol. So these are serious allegations against this magic trial. Even though, even despite all these problems, it showed an overall survival benefit, which was never shown before in a gastric cancer trial of chemotherapy. Now, this is the French trial, FNC-LCC trial. It was published in JCO in 2011. So, in this trial, adenocarcinoma, both of EG junction and stomach cancer, only 25% were stomach cancer. They were given preoperative chemotherapy. This is 2 cycles of CF, then surgery, followed by 3 to 4 cycles of CF. And the comparator arm was surgery, and all they received T2. 25% were gastric cancers. Rest were G junctions, and the 5-year and 5-year OS and 5-year DFS both were improved significantly. But the planned sample size was not accrued, and it has to be stopped early. But this did give us a bit that perioperative chemotherapy benefits. Now came the FLOT4. It was a collaboration of 28 German centers. It was already the initial results were coming in 2016, 2017, 18, but the trial was published in 2019 in Lancet. This is the design of the study. Have a look. This is the gastric cancer or adenocarcinoma of G junction again. Type 1 to 3 sieverts all included. Clinically T2 to 4 or clinically any node negative or any, and M0. They were randomized to FLOT, 4 times FLOT resection, then 4 times FLOT. And then on the comparator arm is ECF, that is the magic. This is the magic arm. ECF or ECX3 resection, and then ECF times 3. So till now, whatever we have seen in the FNCC-LC or the magic trial, the comparator was observation. Comparison was surgery only. This is an active comparator arm. So this is a robust study. We are studying FLOT versus a standard of care, which is magic. Now, what does FLOT stand for? Then we have docetaxel. This is 50 milligram per meter square. Oxaliplatin 85 milligram per meter square, and leucovorin 200 milligram per meter square, all given on day 1. And 5-FU to 2600 milligram per meter square is given by infusion. And mind it, this is not 48 hours. It is 24 hours infusion. So this is a very strong regimen, and this is given every 2 weeks. So FLOT is a strong regimen. What we have changed epirubicin with taxane, and we have changed the platin. We have changed the cisplatin to oxaliplatin here. And does this give us any result? Yes, let's see. The baseline characteristics, if we see, stomach were only 44%. The rest were G junctions. This is the result. We are getting an significant benefit in overall survival, which was our primary endpoint. So hazard ratio, impressive hazard ratio of 0.77, significant p-value. Median overall survival 50 months versus 35 months. So this is the first time that one perioperative chemotherapy regimen is giving us a survival benefit over another strong standard of care chemotherapy regimen of that time. This is highly significant. 2 years, 3 years, and projected 5 years survival, 36% versus 45%. There's significant difference, 14% difference in survival. Now let us have a toxicity. Yes, there was toxicity, but have a look at this. If the vomiting Nausea and thromboembolic episodes and anemia were significantly higher in the ECF arm, not in the FLOT arm. What we had was that diarrhea was high in the FLOT arm because we have both 5-FU and docetaxel. We had infections and neutropenia in the higher in the FLOT arm. And why is this so? Because mind it, GCSF was not routinely used in FLOT. Nowadays, when we practice FLOT, we routinely prescribe GCSF. So these complications are can be managed very safely nowadays. So yes, we did have the different pattern of toxicity, but this was manageable. If we see the side effect, serious adverse events, they were numerically not different, and the toxic deaths were not numerically different between the two. So, what we conclude is that FLOT increased the rates of curative surgery and prolonged progression free and overall survival compared to ECF. And this relative effect from FLOT was considered across all subgroups. And there was no increase in surgical morbidity, mortality, or resurgeries or hospitalization. And this is its character certificate by the ESMO. I think every one of you should go through this magnitude of clinical benefit scale for with the ESMO. ESMO magnitude of clinical benefit scale. This is a very robust instrument which gives the grade to a chemotherapy, to any therapy, whether it should be practiced or whether it should be reimbursed or it should be practiced or not. This gives it a grade A because there's a more than 5% improvement in 3 year in survival at more than 3 years. Okay, so this is a very important regimen, and this has changed our practice since its publication. Most of the medical oncologists have adopted this FLOT 4 regimen for their good PS patients. Now, have a comparison. What I told you, this is the MAGIC trial, this is the FNCC LCC trial, and I've not mentioned this OE2 because this is a purely esophageal trial. And this is the ALBATRA, and this is the FLOT trial. Till now, we had in the comparator, no chemotherapy was there in the comparator, and we had got significant benefit in overall survival. This is the first time in the FLOT regimen that we are having a control arm, which is active control arm, which is the standard of care, and this FLOT is giving us a survival benefit over a standard of care, creating a new standard of care. So this is very important. Now again come to a very $1,000,000 question. If we start with pre-op chemotherapy, we give this patient pre-op chemotherapy, then do a surgery. Then, if we give RT after surgery, will it improve survival? Or if we continue with chemotherapy, will it improve survival? So, this is a very important question. Now, this was tried to be addressed by this trial, which is called the CRITICS trial. This is very, very important. Now, this is chemotherapy versus chemoradiotherapy after surgery and preoperative chemotherapy for a resectable gastric cancer. This is a phase 3 trial. Have a look at the schema. 788 patients from Netherlands, Sweden, and Denmark also participated. They were randomized. Beforehand. Both of them received chemotherapy. 3 cycles of ECF they received. Then they went on to surgery. We can see that 94% of the patient, 93% in this arm, they started surgery. Curative surgery was done for 80 and 84%, balanced. And this was minded D1 or better surgery. And then one arm received chemotherapy, that is the same 3 ECF, and the other arm received CTRT, the chemo plus radiotherapy. And this was completed by 47% and 52%. Now, did it show any improvement? Does this addition of this green thing, this chemoradiotherapy, does it show any improvement? No. There is no benefit from adjuvant chemoradiotherapy if we are starting with a pre-op chemotherapy. So these are the blue and the red curves. They're showing hazard ratio 1.01. This is not significant p-value. So we see that if we start with preoperative chemotherapy, there is no benefit of adding this radiation afterwards. Yes, there were again criticism of the critics. So this is the criticism of critics. People say that 40% of these were early stage. They are least likely to benefit from chemotherapy or chemoradiotherapy, any adjuvant therapy. But mind it, they were balanced equally. Yes, if they were early stage this side, they were early stage this side also. So this does not hold true. And another allegation is that only 50% of these critics patients completed therapy. This is true for any gastric cancer trial, which attempts to give a component which is post-operative. Anything, if you have a post-operative thing, you cannot complete it in 100% of the patients. So with this critics, it gives us a very important message that if you are starting with preoperative chemotherapy, you need not give add radiation afterwards after the surgery. It won't help. Now, to address these questions, we have two more studies which are currently underway evaluating the role of pre-op radiotherapy. Now, this is a Top Gear study. This is being done in Australia. One group is ECF. This is the magic arm, that is ECF 3 for surgery, then again ECF 3. The other group is you give ECF 2 followed by pre-op CTRT with Xeloda and then give surgery. So in critics, we had RT after surgery. Here we are giving radiation before surgery in hope, in an attempt to improve survival. Does it improve survival? So let us see and wait for the results of Top Gear to answer the question that whether pre-op chemoradiotherapy helps or not. Similar is another trial which is called the critics trial. This has been planned. People are randomizing this to 3 arms, that is preoperative chemotherapy followed by D2 surgery, and this is DOC, docetaxel, oxaliplatin, and capecitabine. That is same as the FLOT, similar to FLOT. So preoperative chemo, then D2, preoperative chemo, then a cross regimen like CTRT, then surgery, or just a cross regimen like chemoradiotherapy for stomach cancers and going for a D2 surgery. These are very, very important studies, and we should look out for the results in the near future. They are going to give us very important answers. Now, another $1 million question: if you give perioperative chemotherapy to a patient, or if you go for surgery and give adjuvant chemotherapy for the patient, for example, if you are giving FLOT to a patient, FLOT surgery FLOT, or to other patient surgery followed by capox, is there any difference? Which one is better? So the answer to this was given last year in ESMO. We had 2 studies. One, we had the Prodigy and Resolve. Both are in the abstract phase, and they gave us the answer. In the Prodigy, patients were randomized to this surgery chemo arm with docetaxel, oxaliplatin, and S1 3 times, then D2 resection, and then S1. And this was surgery followed by S1. That is, this is the perioperative and this is the surgery arm. And there was no difference in survival. There was a difference in survival in the favor of the perioperative. So the perioperative arm is better. Again, there was a Resolve trial. There were 3 arms. One is the surgery followed by capox, surgery followed by SOX into 8, and this is the perioperative arm. And let us see the results of Resolve. Arm A versus C. If we see this classic, the D2 followed by Xelox versus the SOX, D2, SOX. This is the perioperative. The perioperative one has a better 3-year DFS. This is statistically significant. But SOX and Xelox are not. So these 2 trials, the message is that perioperative is better than giving adjuvant. So I have told you about a lot of trials. Now, to resolve any confusion, let us now revise things and put things into perspective. This is our schema of things, which has been given by ESMO. These are the ESMO guidelines. We have this preferred pathway, preoperative chemotherapy and surgery. And the trials are MAGIC, FNC, LCC, FLOT, UK trial, French trial, and the German trial. Now, this is the surgery followed by adjuvant chemotherapy. The trials for this are classic, capox trial, ACTS, GC, that is the S1 trial, and the JACRO trial. These are all Japanese. Now, adjuvant chemoradiotherapy, intergroup trial, and CalGB trial. Now, if we compare these 2, what are the trials? This is the ARTIST trial, which compares adjuvant chemo versus adjuvant chemoradiotherapy. Now, this is the if we compare preoperative chemotherapy, and then if we give preoperative chemotherapy and then we compare whether addition of RT is beneficial or not, this is the trial. This is the critics trial. Now, if this perioperative strategy, is it better, or the adjuvant strategy is better? These trials are Resolve and Prodigy, which I just showed you. You must be aware of other trials like POET trial, CROSS trials. These are all G junction and esophageal trials. Do not confuse them with the classical gastric cancer trial. So this cartoon is a mind map of all the major trials which I have just discussed. Just have this picture in your mind whenever you think of which trial addresses what question. Now I will turn you to special cases. What about signet ring cell adenocarcinoma? Does it benefit from adjuvant chemotherapy? So, well, there was a retrospective study from France some years ago which told that if there is a signet ring cell cancer, perioperative chemotherapy gives worse results. Go for surgery only. But this skepticism has gone. In ASCO 2019, the French group has shown the results of this trial. They took only this signet ring cell adenocarcinomas, and then they randomized them to surgery followed by adjuvant chemotherapy or the perioperative strategy. They did not give the full results, but the disease-free survival intent to treat, this shows that perioperative chemotherapy is doing better. So don't worry for signet ring cell carcinomas. We can give perioperative chemotherapy and don't need surgery upfront. Now, special case number 2, what to do for HER2 positive patients? We know that trastuzumab has improved survival in metastatic disease. Will the same thing work in perioperative setting also? In oncology, you do not have 2 plus 2 is equal to 4 every times. It may be 3 sometimes it may be 6, sometimes it may be 5. So until unless you have level 1 evidence with its phase 3 trials, you cannot confirm anything. So the same happened. There was a Petrarca trial, which is a phase 2 trial presented in this year's ASCO 2020. It was 81 patient trial. FLOT was given with trastuzumab. Okay. PATCR improved. It was PATCR definitely improved from 12% to 35% with the addition of trastuzumab to FLOT, but there was a high toxicity, diarrhea, neutropenia, everything worsened, and so this trial was stopped, and no phase 3 trial has been planned now. Now, adjuvant capox and trastuzumab, the results are awaited, and there is another trial which is called the innovation trial, where we are giving there are 3 arms: cisplatin 5-FU with alone, cisplatin 5-FU with trastuzumab, cisplatin 5-FU with trastuzumab plus pertuzumab, and the results are awaited. Until unless these results give us positive results about targeted therapy targeting the HER2/neu, do not venture into giving this anti-HER2/neu agents in the perioperative or adjuvant setting. Now, can we give other targeted agents? Can giving bevacizumab help? So there was a trial published by the MAGIC group, that is the Royal Marsden people, UK MRC. They added bevacizumab to ECX, that is the MAGIC regimen, and they found that there was no difference in overall survival. There was no difference in PFS or DFS. So do not add bevacizumab to these to the perioperative regimens. Now come to a hot burning topic: MSI, macrosatellite instability, high stomach cancers. What about them? Does this benefit with chemotherapy or not? Now, recently, this is the latest molecular classification. We classify gastric tumors into MSI high and MSI stable, MSI unstable, MSI stable. MSI stable are those with an EMT and those which are epithelial, and then again they are P53 positive or negative. This is the current concept. Now, there was an individual patient data meta-analysis of the role of microsatellite instability as a biomarker. So this was published in JCO 2019. 4 trials: MAGIC, Classic, Artist, and ITACA. All 1556 patients of these from all these 4 trials, their data was taken and MSI status of these patients was analyzed. And what do we get? We get that MSI is prognostic. If we have a MSI high, this is the blue curve. These patients fare better in terms of disease-free survival and overall survival. So 5-year disease-free survival and 5-year overall survival for MSI high are remarkably higher. Their p-value is very, very significant. So MSI high tumors do good. This is a prognostic. Now, they have a predictive value also. If we treat these patients with chemotherapy, they do worse. If we don't treat them, this is the green one, only surgery alone, then we do not give them any adjuvant, they fare better. So MSI low, if we give surgery plus chemotherapy, this chemotherapy works. It gives improved hazard ratio. It gives improvement in DFS, gives improvement in OS. But MSI high, if you give chemotherapy, it is detrimental. So DFS decreases, the overall survival also decreases. Now the next thing is how to integrate immuno-oncology drugs. Now these are very hot topics, new kids on the block, and then Epstein-Barr virus and microsatellite instable. These are the two variants. These are the two genomic types of gastric cancer, and we expect these to benefit from immunotherapy. Nevertheless, if blanket trial has been started by the EORTC group, and this is now open in Europe, resectable cancers, chemotherapy, surgery, and then we are giving them the standard post-op chemotherapy versus this adjuvant ipilimumab nivolumab. We have to wait for the results of these. Now, we need a good biomarker to predict that okay, this strategy is working or not. So several biomarkers have been thought of, and PET is an important biomarker. We know that esophageal and G junction cancers, they uh, they have been studied in the Municon trials. Something like this has been proposed for stomach cancer also. So those stomach cancers which are planned for perioperative chemotherapy, they go for one cycle, then a PET. If the PET is improving, that is PET responders, they continue with the same. If these are not PET responder, what is the right strategy? We don't know. So we randomize them into alternative chemo, but maintaining that perioperative thing. That is, we make this white green, or we go for directly for surgery and post-op CTRT. So this trial is also awaited. And last but not the least, we can have a robust biomarker which is called circulating tumor DNA. We have different publications which are very good publications coming up, which came up in recently May 2020, and this was published last year. They tell us that if we have a detectable circulating tumor DNA after surgery, anytime after surgery, it predicts a relapse. It predicts relapse. So in the future, we may have like this. Who will benefit from adjuvant chemotherapy? Those patients who have a positive circulating tumor DNA. Actually, this has been done in the recent COVID times, and people who wanted to avoid chemotherapy, they were given this test in Italian centers. So wait for this ctDNA as a biomarker. So finally, I'll tell you how do I practice. So in my practice, we do MDT discussions for all patients. For clinically T2N0 or higher, we prescribe the multimodality approach, and our favorite approach is the perioperative chemotherapy. For a ECOG PS0 to 1, we give 4-FLOT, D2, and 4-FLOT. This is our preferred strategy. For a PS2 patient, we give doublets, capox or folfox, and try to follow this strategy. For elderly, we have even used paclitaxel carboplatin in very elderly patients. Upfront surgery, we do prescribe to patients who have gastric outlet obstructions, or who are bleeding, or who are occasionally for T2 non-bulky tumors also get surgery done, and they then come to us. Then how do I practice adjuvant? The adjuvant indications for me are T3N plus, or this is what the NCCN also tells you, T2N0 if it's a grade 3, if there's LVI, if there's PNI, and there is an inadequate lymph node harvest less than 15, I'll be inclined to give chemotherapy. And what do I give? I give 8 cycles of capox if there is a D2 resection. For anything less than D2 or R1, we practice the modified McDonald regimen. We give CAPE, CTRT, and capecitabine. Many consultants also use capox, CTRT, capox. This is also another modification. It can be done, but no pre-op CTRT for non-cardiac gastric cancers. And finally, the take-home messages are always do MDT discussion. Perioperative FLOT is the standard of care for fit patients. Adjuvant chemotherapy after D2, no adjuvant RT after D2. US intergroup trial says RT only for inadequately resected patients. Artist 2 says no benefit of RT even after D2, not even in not positive patients. And critics says that no benefit of post-op CTRT if pre-op chemo has already been given. Biologicals like VEGF, HER2, and immuno-oncology drugs are all experimental as of date now. Don't try it in the adjuvant and neoadjuvant setting. Role of MSI is emerging. It's both predictive and prognostic, but its benefit in chemotherapy, there is no benefit of chemotherapy in MSI high, but we have not accepted it currently, like we have accepted for colon cancers, because we do not use only 5FU, we use taxanes also in gastric cancers. And finally, the final message is the quality of the surgery is the key to success in gastric cancer. Thank you very much for your patient hearing, and I'll be love to have your questions.
Thank you so much. Wonderful. Yeah, please, Neelam, continue.
No, sir, please, sir, please. Sir, yeah, please continue.
Your remarks are more important. You are the main purpose of all these academic programs. So something coming from the students are more encouraging to the teacher. So I think you should actually participate in the discussion and comments and everything.
Sir, it was an amazing presentation. Like, it's so clear, so crisp, and like the answers that I actually needed, I got all the answers, and it was a wonderful presentation. Thank you so much, sir. It was really, really good and useful.
And for your information, Dr. Raja, Dr. Dipanjan Panda has commented it as a great presentation. Dr. Indu Bansal has commented it as the most comprehensive, extremely well described. This says all actually. Wonderful.
Thank you.
And I think you have actually included all possible topics and whatever questions can come to mind, starting from all the trials, role of radiation, perioperative, adjuvant, everything, and then all individual special cases. So this is simply awesome. And so there are a couple of questions in the chat box. Let us start one by one. Dr. Satyajit Power has asked, any role of capox based CTRT if D1 dissection done and node positive?
Yeah. So this CTRT can be your modified McDonald's. You can the flanking partners of this CTRT can change. So we have the CalGB trial that if you give ECF in place of this, it also works. It decreases toxicities actually. So anything, if you give Folfox, if you give Capox, if you give D-Gramont regimen, also everything can be seen as useful partners to modify the McDonald regimen to present times. Because the original McDonald, the chemotherapy was too toxic and too weak. So anything can work. Folfox, Capox, anything, and these are all extrapolations. We do not have the level 1 evidence for that, but we do have level 1 evidence for ECF. But in our practice, Capox is very well used in many centers, flanking this CTRT.
Dr. Bharat Mishra has a question. What is the percentage of distal gastric cancer in MAGIC and FLOT? What is the optimum strategy for this group?
Distal gastric, for the FLOT, there were 42%, 44% were gastric cancers. The rest were the proximal cardia and GE junction cancers. Similar was the case for FNCCC, only 25% were there. So, and the optimal strategy is perioperative chemotherapy for these patients.
Dr. Vinod has a question. Studies where MSI was predictive, what was the chemotherapy arm?
So this is a pooled analysis of 4 trials. I mentioned that there was the ARTIST trial, there was the classic trial, there was the MAGIC trial. So these were the chemotherapy arms. MAGIC, we have some patient with ECF, we had some patient with Capox, we had some patients with the ARTIST trial, so CAPSIS. So this was a varied. So it included a combination of platins and 5FU, and mostly platins and 5FU.
Dr. Bharat Nandu has a question. How to decide on peri-op chemotherapy based on location of cancer, proximal versus distal? As most studies of peri-op chemotherapy, the tumors are proximal. So your take on distal tumors?
So a large portion of these have G junction or cardiac cancers, cardiac gastric cancers are there in most of the studies. Even in the FLOT study, I mentioned 44 are the distal gastric cancers, and the rest are around 60%. They were the GA cancer. But this does not prohibit us from taking the perioperative strategy to the distal gastric cancers. So this is the standard of care for both, because overall there was a survival benefit in the overall group, and we do not have subgroup analysis going against it that the distal cancers won't benefit.
Dr. Manish Jathani has a question: how to manage positive cytology during D lab? During D lab with no peritoneal disease in T2N plus disease. Any role of prophylactic HIPEC? So what I understand is it's a T2 node positive tumor cytology on peritoneal washing, and what is the role of HIPEC in these cases?
So take it as metastatic.
Although I'm not sure whether the cytology is done by frozen or what.
Yeah, so T2N0 with cytology positive on diagnostic lab, I take it as peritoneal seeding. Take it as peritoneal seeding and treat it as metastatic disease. Role of HIPEC is not clear in gastric cancers. Very few centers are trying to address this question by in trials. This is not recommended. We have to treat these patients as metastatic disease.
Dr. Ajit Gandhi has asked, is it the time to adapt MSI in routine practice? Have you started yet?
So this is an important question to ask. The reason I tell you, the role of MSI in colon cancers, there was no trial for that. It was that these patients, MSI high patients, don't benefit from capecitabine. They deteriorate with capecitabine. This was just an observation of pooled studies, and there was no prospective trial done, and this changed our practice. So many experts believe that we should do the same thing for gastric cancer also. But mind it, gastric cancer is not like colon cancer. We use taxanes a lot in and now using taxanes in the perioperative setting is very important. Is the standard of care. So 5-FU does not benefit. That's a key take. But in the presence of taxanes, how does this MSI? How will this MSI work? This MSI thing, how much predictive it will be, we do not know. All these trials we have that have been taken in this IPD, most of them had 5-FU only. So we do not know what if you see this in the FLOT trial where taxanes were also used. So we can see that whether this predicts or not. So this is very important. So there is a difference between colon and stomach cancers regarding this, and so we cannot directly accept this into practice like we did for the colon. The mosaic trials, just we had the subgroup analysis, pooled analysis, and we took it to practice. We did not have any prospective trials for MSI in colon cancer, but we need to do this in stomach cancer before accepting, because we have taxanes involved here, not only 5-FU.
Nicely explained. Dr. Shakti Vail has a question. How effective is FLOT for a gastric cancer with gastric outlet obstruction after doing a gastric bypass?
So once we have bypassed, we have done a GJ, and the patient has recovered, and his PS has improved to 0 to 1, FLOT is my choice. FLOT is the best survival, best PAT-CR rates, and best downstaging. So once we have this GJ done, and the patient returns to a performance in 0 to 1, FLOT is the choice. Not for a PS2 or PS3 patient. Not at all. Never with GO.
Now, Dr. Manish Jathani has another question. Indications of D1 plus alpha and beta gastrectomy, which is mentioned in Japanese guidelines published in 2018.
Indications.
I think that should be basic. D1 plus. Okay, we can take the next question.
Yeah.
So, Dr. Bharat Nandu has asked in continuation of his earlier question. So, for an operable distal gastric cancer, which is better, upfront surgery followed by adjuvant treatment versus peri-op chemo then surgery then adjuvant?
Peri-op is always advisable. Peri-op is always advisable if we do not have any gastric outlet obstruction there. Obstruction, bleeding, you take these patients for upfront surgery. Otherwise, perioperative is the standard of care for all. For all. That's my
And
take on this.
Dr. Indu Bansal has commented, patterns of failure after D1 and D2 dissection are different. After D2, most common site of failure is 16A2 and 16B1, which are not dissected. 33% recurrence rate have 33% recurrence rate even after D2, which cannot be compensated by only chemo.
Well, I agree. Yes, these have been there have been reports like that. So, but if we have to see the rates of distal failure, peritoneal failure, and the distal failures also. If, even in the if we see the intergroup trials also with the radiotherapy in the radiotherapy arms, the pattern of distant failure was same. So, okay, I agree that 16, the station number 16 is a site of failure even after D2. But these are very small number of cases, I suppose. So after D2, I don't think RT adds much, and these are a small number of patients. I don't think this is a big chunk.
Now, as because it's a pandemic going on, we cannot avoid questions related to pandemic. So Dr. Manish has asked whether, because this COVID pandemic is going on and patients come with partial gastric outlet obstruction, whether a nasojejunostomy tube placement followed by perioperative chemotherapy is a suitable option.
So during this COVID times, most medical oncologists have been pushed by their surgeon colleagues for a NSCT approach. We are pushing the walls of NSCT, so we are giving more and more. There is nothing right and wrong for this if your surgeon is not willing to operate a gastric outlet obstruction up front. But uh, it it will not be a foolproof option if the patient has a gastric outlet obstruction. So these are and you give a nasogestric and nasogeninal tube to bypass this and start chemotherapy. Okay, you can buy some time with this. There's no right and wrong answer for this. So, but the preferred option will be at least go for a palliative GJ and then make him better suitable for the perioperative chemotherapy.
The name is not visible. It's being shown as I. So Dr. I has a question. Any role of definitive chemoradiation? Any evidence?
So there are retrospective evidence of definitive chemoradiation for patients for upfront unresectable patients who were treated with preoperative chemotherapy, and then even then they become unresectable even after exploration. So most of these patients, in my practice, I've seen a bulky celiac lymph nodes. They do not convert, even if they do not convert to resectable whatever chemo you give to them. So I have tried this in definitive CTRT in these patients, but they fail after a period of time, a very short period of time. So this is not very radical as is supposed to be. If you call it definitive CTRT, of course this is an option, but evidence is limited. Even my practical, I have experience of 2-3 cases, but they didn't work well.
There is a question from Dr. Avirup Chanda, and we should take it with great importance. Although he has apologized, I think there is no reason to apologize. Sir, my father is 60-year-old. Is asking for a personal opinion. My father is 60-year-old, stomach signet cell adenocarcinoma post D3 subtotal gastrectomy, pathological T1A, N1, 1 out of 23 lymph nodes positive, LVI positive, completed 6-cycle adjuvant ECX in February 2017. We do yearly PET CT and upper GI endoscopy, 3.5 years down on follow-up. How long and how should we do the surveillance?
Okay, that's a great question. How do we follow up patients? So I'll tell you my practice for locally advanced stomach cancers who have been curatively resected. what we do is clinical history and physical examination every 3 monthly for the first 2 years, and then from third to fifth year it is 6 monthly. Now, imaging and upper GI endoscopy. For imaging, we do it at 6 to 12 monthly is the norm given in NCCN. But what we do is that we do yearly CT scans, and every we alternate CT with USG and chest X-ray. So 6 month, after 6 months we'll do USG and chest X-ray just to reduce the exposure, and then after 6 months we'll do a CT. So alternating USG, chest X-ray, and CT chest, abdomen, pelvis, and along with the markers CA at 19.9 at every visit. So this is how this is our pattern of surveillance, and this is very important. First 2 years make it intensive 3 monthly, and then third to fifth year give it do it 6 monthly.
Yeah, I still remember that follow-up protocol at our stage.
Yeah.
Dr. Indu has commented that the IMT trial had poor radiation technique. Ma'am, we really face all these radiation oncologists we face all these things.
I agree. I completely agree.
Our trials are always very much criticized, but no one speaks about those things that the trials done at 90s or early 20 in 2000.
Yeah.
They were having very poor techniques, all standard two-dimensional radiation, irradiating a whole abdomen, and then comparing with all fancy chemotherapies. This is perhaps not right, but that is how we are helpless. We don't have adequate trials to comment on this.
Definitely.
More trial utilizing rapid arc, utilizing tomotherapy, utilizing proton, and perhaps that would be the best way to complete this debate.
Yes, this is a never-ending debate. It will remain, but whatever I could synthesize.
We feel sad that, logically speaking, the radiation sterilizes the tumor bed, and chemotherapy takes care of the systemic component of the disease. So, logically speaking, adding radiation should increase local control, but that does not happen in clinical trials. Now, what are the lacunae of those trials? How good was the radiation plan? How good was the radiation contouring? Because we speak a lot about surgical quality, we never speak about quality of radiation.
Definitely.
So, definitely these things are very important. But until and unless we are having some robust randomized study, it's very difficult to comment, and I really do not find that that's going to happen very soon, because it's now all about chemotherapy and chemotherapies. Even now, G junction is now, I think the role of radiation is gradually becoming diminished after this flawed trial. So something that really you have to accept.
Yeah, that's it.
Dr. Dhanraj has a question. Patient presenting with para-aortic node upfront, how to manage considering it requires a D3 dissection?
Para-aortic lymph nodes is a M1 disease. This is anything beyond the celiac axis is metastatic disease. So consider it at M1 disease. Treat him with a palliative intent.
Dr. Rakanuzzaman has a question. D1 resection, N0, 15 lymph nodes dissected. Can we avoid radiation?
No.
I think this question does not give enough information whether the pre-op treatment, whether it was a peri-operative or what.
Yeah.
It does not give adequate information. But still, what will be your take on this question?
So had it been an upfront surgery, D1, even 15 lymph nodes, adequately resected lymph node, but if it is D1, then only chemotherapy is not adequate. We have to incorporate RT to it.
Yes.
Management.
So I think many more questions are pouring in. Is all the effect of your fantastic presentation? Will you agree to take a few more questions?
Yeah.
Okay. Then let us take this question. Dr. Arnav Banerjee has asked, modifications of D2 entails leaving station 10. Is that enough to call it a D2 outside Japan?
Oh, this is a purely technical surgical question. So, leaving that splenic hilum.
I think we have a question. We have a session on surgical aspect of stomach cancer on 19th or 20th.
I think it will be better answered there.
I would sincerely request you please be present on that class. We have a dedicated session for surgery in stomach cancer. I think we will be more enlightened by our surgical teacher.
Surgical colleagues will be better answering this.
Yeah. Any more questions left? I think we have covered everything. Your take on sensitivity of PET scan in signet ring cell carcinoma?
Yeah, they are not very much PET avid. So this is a caveat. So whenever you are using PET, you have to have the baseline, whether this was avid at baseline or not. Some CS stomach are notorious not to have FDG avidity at baseline. So if you are using this, always make sure that you have a baseline to show that this tumor was really avid at baseline.
Yeah, Dr. Nilam, please go ahead. Dr. Nilam, you had a question? Okay. Any recommendation for oligometastatic CS stomach? Should we start off with flawed, and if the metastatic site responds, go for surgery? Dr. VS.
So the stomach is not a disease I will recommend for a curative approach for oligometastatic disease. So, but FLOT has been tried in this setting. There have been studies where FLOT have been tried, but the definitions of oligometastatic is a moving concept. It's for stomach cancer. This is not like colon cancer. So this is a different entity altogether. Its metastatic potential, its natural history is different. So metastatic disease has to be treated with a palliative intent. I won't advise curative resection for these patients because most likely you are going to fail for oligometastatic disease in stomach cancers.
True. I think it's going to be a dynamic thing. A lot of areas and subsites which earlier used to be considered as incurable now are coming under the purview of oligometastasis, and people are trying a lot to make them curable. We recently had a discussion on lung cancer, on head and neck cancer, and we have seen that treatment approaches are currently changing very rapidly. Even in lung cancers now, having metastasis of up to 5 in number being treated with radical intent, and those trials are really showing impressive results. Although it's yet to come for CS stomach, but we can only hope that it will come someday.
Yeah.
Okay. Any more question from anyone? Okay. Dr. Ajit has a question. Role of PET-CT in initial evaluation.
No, PET-CT is not the recommended thing in the initial evaluation. You can very well do it with a contrast enhanced CECT, chest, abdomen, and pelvis. But if you have the facilities, you can go with a PET-CECT. Most of the surgeons nowadays they want a PET-CECT because of the ability to detect distant mets, not because for the local therapy, local staging, but for determining the distant mets, which are often missed with PET and missed in the CT, and PET picks a lot of them and thus prevents futile surgeries, upstages the disease, and changes the management strategies. So CCT is enough. It is the prescribed thing. But if you had nothing against doing a PET CCT, but contrast enhanced CCT is the standard of care.
The next question from him is role of diagnostic lab for initial evaluation.
Yeah. See, there have been studies for this. For example, if you see the Critics 2 trial, which is the latest, which is if you see the protocol, it begins with a diagnostic laparoscopy to detect those peritoneal mets early on for each and every patient, then randomize them to dissect out the M1 disease upfront. But it is not feasible for everyone to go for this with diagnostic laparoscopy upfront. We do not use it. Recently, we are having one trial in ISCH with diagnostic laparoscopy in GB trial in gallbladder and stomach, in which is being run here. But we can do it before attempting surgery for unresectable disease, or those who have not have the sufficient sufficient reduction, sufficient cytoreduction or volume reduction after pre-operative chemotherapy. Going for a radical surgery, before going for a radical surgery, you can do a diagnostic lab, check for peritoneal metastasis. And not for every patient, it's not recommended.
I think, so Dr. Avril Chand has another question. How long to follow up with radiological imaging after radical treatment?
So I told you our protocol is intensive for 2 years, then 3 to 5 years, 6 monthly, and then after 5 years yearly, and depends on clinical presentation of the patient. Keep it 6 monthly, simple, even after 6 months, because this was a significant cancer to begin with. So never lose him to follow up. Continue follow up. I'll not advise to stop follow up in these patients. Survivors have to be followed up lifelong. You can reduce the intensity, of course.
Great. Thank you, Dr. Raj. I have no words to thank you and for your lovely presentation.
Actually, my pleasure to be on screen in front of all of these patients. I was fortunate that I could interact with all of them. My message could go to this audience.
It's very clear. We are really thankful to have you.
So thank you very much.
Okay.
Thank you, sir.
Someone has asked me to mention the YouTube channel. So the name of this academic group is Oncology Classroom. The name of YouTube channel is also Oncology Classroom.